Today's conversation is one that's very close to my heart. Recently, someone we cared about deeply, Justin Lesh, passed away from a genetic heart condition called Hypertrophic Cardiomyopathy, or HCM. And what's so difficult about this condition is that many people don't even know that they have it. It can exist quietly for years, sometimes for an entire lifetime, without obvious warning signs. People can look completely healthy, live active lifestyles, and still be at risk. That's why awareness matters so much. If more people understood the symptoms, knew their family history, or simply knew what to ask a doctor about screening, many tragedies could potentially be prevented. And that's really the goal of today's conversation: awareness. At the same time, we talk about cardiovascular health. We can't look at it in isolation. The heart, the arteries, circulation, it's all connected. Conditions like peripheral artery disease are part of a bigger picture of vascular health that patients often do not fully understand. So today, we're going to talk about HCM, what it is, the symptoms people should never ignore, who should be screened, and what families should know. And we'll also talk about why broader vascular awareness matters, with the help of the incredible advocates like Kim McNicholas from the PAD Global Association and Dr. Raj from Champion Healthcare, who's an interventional cardiologist. If even one person listening today decides to get checked, talk to their doctor, or ask about their family history because of this episode, then it's well worth it. Hi, everybody. Welcome to the OBL and ASC Marketing Blueprint segment brought to you by Patient Pro Marketing. Today's episode is focused on hidden heart conditions and vascular health. This one is really personal to me because I lost my dad to heart disease, but more recently, I lost my dear friend and business partner, Justin Lesh, to a condition that many people have never even heard of called HCM, or Hypertrophic Cardiomyopathy. If this conversation can get one person screened, today is well worth it. With me, I'm joined by two incredible voices in the vascular and patient advocacy space: Kim McNicholas with PAD Global Association and interventional cardiologist Dr. Raj from Champion Healthcare. Thank you so much for both of you being here to help bring awareness to such an important conversation.
Thank
Um,
you.
Excited to be here. Thank
yeah,
you.
thank you. And I know you both had a personal connection with Justin. If you want to share anything, please feel free.
I'm happy to share first, just because the first time I met Justin was at OEIS, the conference. I think it was last May, so just a little bit less than a year ago. And his energy just fills the room, and it's just contagious. And his passion and commitment to helping patients is just so admirable and, again, contagious. He was always well spoken, so much so that when I had an opportunity to have a co-host for a live broadcast for our weekly radio show, which was the number one in innovation, women in innovation podcast in the nation last year. Of course, I have to have a male co-host, right? So I asked him to broadcast with me live from Dr. Sid Rao's genicular arterial embolization conference. And it was so fun. And he was fantastic at bringing in patients and drawing out the best in them and relating to them and showing so much compassion. Just, he was a wonderful human, not only brilliant and creative and passionate, but such a good human with a huge heart, doing everything for the right reasons. And I was shocked to hear that suddenly he was gone, because I was excited to move forward with having him do additional videos with us and co-hosting in additional segments moving forward. But I know he's going to be with us in spirit moving forward, and his impact on so many across the US, it's going to live on forever. So I hope that his legacy lives on and many people tune in and stay tuned in to this episode to get screened in his honor, so that something like this does not happen to him, because it's something that you might look healthy, and he looked healthy. He was completely fit. And if people would say, "Oh yeah, he looks healthy. He's great." And then suddenly he's gone. And that's the way this disease can work. It can silently just come in and knock you out. So I can't wait to hear what Dr. Raj has to say, and I'm going to take a step back. But thank you for the opportunity to share my love for Justin, and we really appreciate him so much.
Of course.
Yeah, this one is very personal to me as well, because I have met Justin in OEIS, but not seen him before, but had nice, good conversations with him, and we had a podcast. Um, I think it was a Friday, and when I got a email the next day, I was totally shocked, and we thought we both clicked very well, and we had a lot of similar thought process on a holistic approach on every problem. And and I sent a when I got this email, I was like shocked and could not believe. And I thought this is going to be a scam, or uh, I want that news to be really a scam.
Yeah.
And it really hurt me. Um, but first I need to thank you for this conversation, because it truly matters. Uh, Hypertrophic cardiomyopathy, or HCM, is one of the most common inherited conditions, affecting roughly 1 in 500 people, and yet many people have never heard of it. The tragedy is that individuals feel completely healthy until something seriously happens, like what happened to Justin.
Yeah.
So, if this discussion helps even one family get screened earlier, then it absolutely matters.
Yeah. Agree. And I'm so glad and grateful that you're here, Dr. Raj. I know for you and me both, it does touch home, right? Because we had a podcast just a few hours before he had his incident. So I couldn't think of a better person to be on here right now to represent him and talk about this. So can you, for everybody listening, in simple terms, explain what is HCM?
HCM is a condition where the heart muscle becomes abnormally thick. When the muscle thickness, uh, when the muscle thickens, it can make the heart harder to beat and pump the blood effectively. Uh, what I would say is, like, just think like a room where the walls are slowly moving inward, and eventually there's a less space for the blood to move through. That's in simple terms, that's what is happening with hypertrophic cardiomyopathy. There's not enough blood coming out of it's not coming into the heart and not going outside the heart.
Okay.
How does it sneak up on you, though? How does it sneak up so, you think you're healthy and then suddenly you're gone? Is
Right.
it that quickly for most people?
So first thing, we need to understand the hypertrophic cardiomyopathy itself is not a very well recognized disease, and most people are healthy,
Mhm.
and they don't know they have this disease unless there is a family member affected. So there are many reasons that hypertrophic cardiomyopathy causes you to have a sudden cardiac death.
Yeah, when I did my research after hearing this, everything I read was like young athletes, fit people, right? Everyone knows Justin came from a fitness background. He was probably one of the most healthy people that I knew. Um, in fact, and really the only thing you can do is genetic testing. I have a friend who has this condition as well. He's a year or two older than me, and the
Mhm.
only way he found it was he started to get really lethargic all of a sudden. And his wife, of course, the wife was like, "Go to the doctor, get checked out. Like it's the lethargy is too much for like what you're doing." And because he was not a very healthy, like went to the gym kind of guy all the time, he went to the doctor, and that's where they did ultrasound or echocardiogram and found this out. He's had 2 open heart surgeries now, and he's on the heart transplant list at 49 years old.
Wow.
But you only know, and then he had the genetic testing, and boom, found he had one of the genes. When they did Justin's genetic test, and he had both of the genes. Um, and you can go back and say, "Oh, I wish he would have got tested, whatever," because he did lose his dad, I believe, to a heart attack a couple of years ago as well. But you think, "Oh, he's older, he smoked, he was in bad health." think, oh, maybe it's a genetic thing and I should go get checked, especially when you're as healthy as someone like he was. Um, and I think that's the scary part about this disease, doctor, is like, what are some of the symptoms you should look for besides, hey, my dad had it, so I should get genetically testing? Like, what are some of the symptoms people should look for?
So, you know, as you said, because many patients do not have symptoms for many years, and it is going to be very difficult for someone to identify if they have a hypertrophic cardiomyopathy, because the heart can compensate for a long time. Without, like you said, without screening, the condition can only be discovered if they have a like a fainting episode or an abnormal EKG or a family tragedy like this. Otherwise, most patients are asymptomatic. Yeah, I mean the thing is, uh, not everyone gets an echocardiogram to really know, because we don't really have to have an echocardiogram unless you have symptoms.
Mm-hmm. Yeah. Um, I've had one. I just had one probably 6 or 7 months ago because I was getting lightheaded, but I have very,
Mhm.
very low blood pressure. And I even remember talking to Justin about this, that I had to go to the cardiologist. And also knowing my father's history with heart disease, I take it very seriously. I've had plaque testing and everything done, just because I know it's in my family to pass away at early low 50s. Um, I'm not there yet, but I'm getting close.
Yeah.
So, I guess I would ask you, if anybody was watching this, right? What kind of advice would you give another family uh, to take precautions for this so this doesn't happen to somebody else?
So, what we should do is that there are actually, when you read the literature, there are three groups that should absolutely consider screening. First thing is anyone with a family history diagnosed with hypertrophic cardiomyopathy or HCM. The second one is anyone with unexplained fainting or exercise related symptoms, uh, and families with unexplained sudden cardiac death under the age of 50. I know that you had, if you don't know, these are the three categories. And when you asked about, what are the other symptoms, it's if a patient has like unexplained shortness of breath or a chest discomfort during exertion, or most of the time it's fainting or like a near fainting episodes, then palpitations, and as with every other, like with Justin, what we are talking, a family history of sudden cardiac death.
Hmm.
The symptoms can be subtle, and people usually dismiss them as like a stress or fatigue.
Yeah, or dehydration. That's what he used to tell me, that he would tell me he would get lightheaded, and we would literally share uh electrolytes. Like we'd bring electrolytes with salt tabs to meetings together, or like, hey, you should try this one. We would send each other links because he would tell me he just doesn't drink enough water.
Correct, correct.
Yeah.
And if you have to like screen someone, it's very easy. We know that if you can have an EKG, electrocardiogram, or echocardiogram, heart ultrasound, these two actually can find a thickened muscle and any electrical changes, because that's a very simple test, and almost everyone has access to this. But we do not have like a screening. For example, if you take a prostate. If a patient has a prostate, if they have more than 50 years of age, males get a PSA, and colonoscopy screening has become very widespread because they always think cancer will kill someone. And so they have a colonoscopy done on every individual, 45 years of age or older. Maybe, because it's more prevalent, like 1 in 500 people get hypertrophic cardiomyopathy. Why not have a new guideline informing, anyone with 20 or more to have an EKG and echo, which is simple test, not an invasive test when compared to the colonoscopy.
Yeah, like a preventative screening, right? To get a baseline where you at, especially if
Correct,
you have
correct.
XYZ risk factors. And that could be done probably in like a normal yearly physical, right?
Yes. And currently the guidelines have only are supporting people who are undergoing athletic activities, that you need a pre-screening. And we know in hypertrophic cardiomyopathy, the blood is not pumping out of the body because it comes to the left ventricle, which is the lower part of the heart. And when it's trying to get out of the heart into the aorta, that is a tube between the left ventricle and the blood flow to the whole body, it's narrowed. In hypertrophic cardiomyopathy, when they exercise, it actually narrows more. And that is the time when these individuals have arrhythmias and they pass out.
Or worse, right?
Yes.
Or it's fatal. Um, Kim, let's talk about patients with PAD because you have a huge following and a ton of patients, thousands and thousands around the world that you've helped, and I feel like sometimes people often separate heart disease and vascular disease, and I'm sure you hear that a lot. How important is it for patients with conditions like PAD to look at the overall cardiovascular health? Like, how do you in the organization handle that?
In working with more than 12,000 patients across the globe through our association and our network, we've discovered that patients with PAD typically have other comorbidities. You don't find sick legs on a healthy person. And we find that with most patients who do have the atherosclerosis in their leg arteries, causing that poor circulation known as peripheral artery disease, that they do have something going on with the heart. And we have had actually, and I ended up having to go back into our EMR system where I discovered that we've actually had more than 3 dozen patients with some form of cardiomyopathy that had been diagnosed after working with us. And we sent them to a cardiologist. With every single patient who has a vascular issue, we always tell them that they should have a cardiovascular evaluation that at the very least includes the stethoscope on the heart. We say to chat, CHAT, check the carotids with the stethoscope, the heart for AFib, valvular issues, the abdomen for any sort of turbulent flow, what we call a BRUI, spelled brute, and then, of course, T, the toe, to check for that poor circulation in the legs. But heart being most important. So at the very least, we got the stethoscope. We say secondarily, especially if you have PAD, it's likely that you do have atherosclerosis, not only in your leg arteries, but also in your coronary arteries. And so we suggest them, especially if they're not walking very far. And I know this is going to be controversial, but I think Dr. Ramaraj would support what I'm saying here. Is I always suggest getting advanced testing at the very least, getting the EKG, getting an echocardiogram, which will also screen for other hereditary issues. We find so often that they do have other structural heart issues or even aneurysms. They all have hypertension, right? And so that can lead to other things that just can silently sneak up on you. But a stress test, a nuclear stress test, very least. But I think that still, for me, my opinion is the gold standard being the PET scan. But I've had some vascular surgeons that will tell me, I do not send my patient to a cardiologist unless they expressly tell me that they're experiencing angina. And even if they express shortness of breath, it's not necessarily to the cardiologist. They're sending them to the pulmonologist because so many of them have been either smokers or former smokers. So they might have COPD. So many have COPD. They need screen for lung cancer, of course. But I think it's really important for every single patient to have that holistic approach. And the very least, to see a cardiologist, have an initial assessment, and have that cardiologist not say, okay, are you experiencing angina? Let's talk about shortness of breath upon exertion. Let's talk about, are you walking slower than you were a year ago? And are you getting up to a pace to where you might experience these cardiac symptoms, right? Because if they're not getting up to pace, at least right now, because they're struggling to walk with their PAD, they might not get to a point to where their heart is at risk yet. And it's still silently building. With cardiomyopathy, the thickness continuing to get thicker and thicker, the atherosclerosis continuing to build. And then it's just that one moment, that one additional exertion, and they're done for. And so every single patient needs to be their best advocate. And they need to say, you know what? Even fatigue is the new angina. There's a doctor who's a CTO pioneer, crossing pioneer for coronary out of Chicago, Dr. Parag Doshi. And he spoke to our group and said, the new angina is fatigue. And the only way that you can determine if someone is at risk of a heart attack is literally to ask them the question, are you struggling to walk? Are you walking the same distance and at the same pace as you were a year ago? Not, do I have chest pain?
I was going to ask you on the patient side, because, most patients go to the doctor and they just listen to the doctor. They don't know what questions to ask. You know, I don't know, Dr. Raj, in your experience, if a patient came in this educated, right, and advocating for themselves, I think that's great. I don't think you probably have a lot of patients that do that, right? I mean, do you have patients who come in and really aggressively ask, like, I need this, this, and this is what I'm feeling?
I mean, most of the patients, and especially, they only come at the very late when everything is like, always we say, it's a hindsight is 50/50. When something happens, then you come back. I mean, there are some very educated patients who take care of their health seriously and going to the primary care and try to be upfront with some questions. And not everyone is a medical doctor who can understand what is happening. Just like Kim said, even though hypertrophic cardiomyopathy and PAD are different conditions, but they highlight an important point here. The cardiovascular health is interconnected, and patients with a vascular disease often have multiple other risk factors for heart disease, arterial problems, and circulation. The whole body is a vascular trees are connected. I see with the patients with a PAD, peripheral arterial disease, you have a 30% chance of having a coronary artery disease, which is the heart disease. Then you have same thing, you have another tree called a cerebrovascular disease, which is a stroke, which we don't talk about also. So we have a cerebrovascular disease, cardiovascular disease, peripheral vascular disease, all are connected, and so uh, and I am the one thing most of our patients don't understand is, because just the legs are hurting does not mean that that's the only part that needs to be treated, and don't want to have like a tunnel vision and just treat only one thing, but not holistically treat the entire body so that they can get treated and live longer and reduce the atherosclerosis. So I mean, like, uh, at the end, yes, the education is very important, and and kind of the podcast that we are doing will help patients, when they're driving, they can listen to this podcast and try to identify what they have. And also, that's the reason I try to talk to them in a way that they can understand the disease. Not everyone is going to understand when we are going to be talking uh, someone with the medical terms. So I try to dumb down to a level that everyone can understand.
Yeah, I think that's what's so great too with Kim's organization at the PAD Global Association is that they don't know claudication, they don't know peripheral artery diseases, right? They're just, unfortunately, I've seen it. I watch and follow so many of her patients. Like, they don't get the attention until their foot is about to get cut off, right? And it's that aware, like, how do we get people to be more aware before tragedy, before your only option is to go on a heart transplant list, have open heart surgery and or term from it, or have to have an amputation, a major amputation, like your foot, your leg, below the knee, whatever. I wish there was more resources for patients on both, right? I know PAD can be doing a phenomenal job, but it's not enough. There's still thousands and thousands and thousands more people that we could help and try and reach out to. Um, what tell us if there's anything you want to share right now about the Global PAD Global Association and how people can get in touch with you. I see you've got your phone number and stuff in your background there. But for people driving, like what are some resources where they can reach out if they have concerns about vascular disease? And then Dr. Raj, we can let you kind of close out with any closing marks about HCM too.
Yeah, I mean, in terms of the Global PAD Association, we have our Leg Saver hotline, and it's a great resource with someone always answering the phone to be a friendly voice on the other end, to spend whatever time you need to just talk about what's happening with your symptoms. We do not, and this is very clear, we do not give medical advice, we don't diagnose, we don't offer treatment. We do have our lifestyle support programs, diet, exercise, and of course, smoking cessation. So we can support people with that. We have weekly seminars and office hours with doctors who are available, not again to diagnose or treat, but to help you to better understand your presentation of disease and offer you some critical questions to take back to your care team so that you can have a more productive and satisfying conversation with them about your care. But it's also about letting you know what different options are available. We're getting ready to launch padtrials.org, and we've launched with the NHS and have had great success with partnering with the NHS out of the United Kingdom with all of their trials and focusing there. And we're now spreading to the US to offer a one-stop shop for patients to access all of the different trials that are available out there. So if they have no option or they want to know other options that might be available, whether they're in early stage or advanced stage, they can go to this one site and not find out which doctors are doing them. They can find out about the trials, and they can find out what's happening in their city or their area within 50 miles, right? But then they can call us and then find out for who those doctors are, and we give them a warm intro to those particular doctors that are participating in those trials if the patient is potential fit. So we have a lot available, but it starts with 1-833-PAD legs that they can just call, talk about their symptoms, and we help these patients in a very comprehensive way. That it started out with just PAD, but sick legs are not on healthy people, right? Again. And so a lot of these patients find out how we advocate for them for their legs. And then they come back to us and say, well, now what do we do? And for example, last week we had a patient who was getting ready for an aorta bifemoral bypass. And her mom had just died 2 years before, and her dad had died all of heart issues. And I said, you know what? I'm wondering if your heart is throwing clots. Do you have any heart issues? Have you ever had your heart checked? No, she's never had their heart checked, and they were just going to do a basic consult with the cardiologist, very basic. Just, oh, here's the EKG, and do you have any symptoms? We'll send you on your way. And I said, no, 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 no. You're going in for an aorta bifemoral bypass. You need to have a comprehensive look. And we also need to understand, is your heart throwing clots, or where could these clots be coming from before we do that? And we help the patient advocate for themselves with critical questions to discuss with their care team. We even help expedite appointments, which we did with a cardiologist, and a comprehensive review of the case. And lo and behold, we found there was a valvular issue. Go figure that the heart was throwing clots. So imagine they go in for the aorta bifemoral bypass, and weeks later it's already blocked. Yeah. So that's what we really do to help these patients. Just whatever you need, we're just here to talk.
Yeah, it's awesome. I think what you guys do is amazing. And Dr. Raj, we just before we got on this call, I didn't realize you've got several published papers about HCM. I don't know if those are, out somewhere where anyone can, if that wants to learn more about them, can get access to, if those are more in some of the clinical journals. But anything that you want to close out with here would be great for everybody.
Uh, and thank you, Rachel, for arranging this and Kim talking about PAD. To know about hypertrophic cardiomyopathy, they can go to the NIH website, but I can give you the website later. It is in PubMed, PubMed. So these are all the publications there. You can go, and many are free articles, and there are a couple of my articles also available for hypertrophic cardiomyopathy that I have published. So you could do that. And so the the awareness. Okay, so what should a patient who is or person who is listening to this should think about? Should I be screened for HCM or hypertrophic cardiomyopathy? Do I need an echocardiogram? In a simple term, ultrasound of your heart. Should my family members be tested? Do I need genetic counseling? These are the questions you may have to start thinking about. Heart disease does not always come with warning. There may be no signs. Sometimes the only clue is family history. Good news is screening works. And when we can catch conditions like HCM or hypertrophic cardiomyopathy early, we can prevent devastating outcomes. So the most powerful thing anyone listening today can do is simple. Know your family history, ask questions, and do not ignore your heart. Thank you.
And can I ask really quickly, what are the treatment options? So if you do catch this, is it medication and annual screenings?
Mhm.
Good.
I mean, the first thing is, you don't even have signs for uh, the hypertrophic cardiomyopathy. The treatment is mainly depends on the severity of the symptoms. The common options they currently use is beta blockers, or calcium channel blockers. These are the medications just to improve the symptoms like shortness of breath. And there are new medications that actually target the underlying heart muscle function itself. There are two medicines currently they have developed, which actually reduces the contraction of the heart muscle. It's called mava catum. It's a new medicine, Aficam 10. So these are two medications which actually improve the heart muscle function. And in some cases, they actually can reduce the thickened muscle. One is called a septal myomectomy, which is a surgery that they shave the extra growing muscle. The
Yeah,
second one is
that's what my friends had twice. He said they
oh,
shaved my inside of my heart. Those are his words.
correct. The second one is what they do is they also do a like an alcohol ablation. They go to the artery, which is supplying the thick muscle, and what they do is they do an artificial a minor heart attack in the thickened muscle. So when you have a minor heart attack within the thickened muscle gets smaller, and thereby you get more blood flow coming out. In certain individuals who are at a higher risk of having arrhythmias or death, we recommend implantable defibrillators, which is like a pacemaker which goes under the chest wall. So this would have been a situation where we could have found Justin. We could have saved him if he had this defibrillator. So there's no real treatment available. That's what I'm trying to say, but it's only the symptom management and preventing sudden cardiac death.
Okay. Well, thank you so much for both of you being here. Again, bringing awareness to a really important topic that touches us all, right, in a personal way. But also, I know Justin's family is really going to appreciate us just helping prevent another family from having to go through such a tragedy. So, again, I appreciate you both so much. Thank you so much.
You're welcome.
Thank you.